Maybe I would just present it the way you will see this patient. We don't see the patient with a diagnosis. We see the patient through a series of events before we reach the diagnosis to make it more interesting. This is one of the patients that we encountered recently, November last year. And he presented, he's a 75-year-old gentleman. General health is actually quite okay, not immunocompromised. And he presented with diplopia and headache for 3 weeks. The headache has been there for 3 weeks, but the diplopia is sudden. So much that he need to taken to the A&E department and was admitted. And apart from that, he has no nasal symptom and his past health is good. Initially, he was managed under the physicians. And this is clinically the only physical sign we can have patient with sixth nerve palsy. Although there's some suggestion that apart from the sixth nerve, which is totally in function, the patient actually find it difficult to move the eye up and down. So there's a possibility that there's actually more than a sixth nerve palsy. And the other cranial nerve is intact. And endoscopic finding was quite normal, except that the sphenoethmoidal recess, we see some fluid. And this is because we are consulted. And let me see. A CT scan actually was done before the consultation. And the CT scan, in the CT scan, what was shown was that the left sphenoid sinus was completely opacified, and there's soft tissue mass with variable densities, and that it seems to be invading into the cavernous sinus. If I can show you this set of CT. So maybe to summarize, this is a gentleman quite well before and presented with 3 weeks history of headache and a sudden onset of sixth nerve palsy. The other cranial nerve seems to be intact, except up and down gaze of the patient is also being affected. And this is a CT. This is the most relevant CT that I pick up. You can see the rest of the sinus are quite clear. The sphenoid sinus completely opacified. And there seems to be erosion of the lateral wall of the sphenoid sinus. And further than that, nothing quite unusual. And if you look at the coronal images, again, here is the sphenoethmoidal recess area, the posterior ethmoid clean. And the next cut, you can see the sphenoid here completely opacified. And if you come to this cut, you can see that the lateral wall, supralateral wall of the sphenoid sinus appear to be eroded. Again, and here.
You got an MRI, John?
Later on. At this stage, we don't have the MRI yet. And then on with contrast, you can see that the cavernous sinus seems to be enhanced as well. And so at this, we are consulted with this sort of information. A relatively healthy gentleman presented with 3 weeks history of quite severe left side headache, and then suddenly present with left side diplopia. And neurologically he was normal otherwise, but a CT scan for the brain happened to pick up that this patient got a completely opacified sinus pathology, which appeared to erode the lateral wall, and on IV contrast it seems to be enhancing, and the left cavernous sinus seems to be involved. And we are seeing the patient at such a stage. So I can actually go on, but I think to make it more interesting and the discussion more also challenging, interesting, I would stop giving you other information, and we can have a little bit of discussion at this stage.
Maybe you want to get some audience.
I think so. Yeah. I think I would like the audience to be involved. I think of last year's presentation, one of the things that I remember very well was the cases that we present, and we really learned from the cases that we presented. And if I can come across such a patient, you may come across such a patient, maybe next week, maybe next month. Yes, any question?
I'm an ophthalmologist, so I have a few differentials when I see a third nerve palsy and a dilated pupil.
Yes, the dilated pupil was not 100%.
Yeah, but it's still, if it's anisochoric, meaning if the other one's normal and the other one's a little bit dilated, You have to. It's a.
You are quite right. Actually, we
It's
confirm.
either two. It's either a aneurysm in the cavernous sinus, or it's a mass.
Yes,
invading the
that is
cavernous
actually
sinus.
what is in our mind too. We did consult the ophthalmologist. They did fundal examination. There was no evidence of papillary edema, and they also comment that sixth nerve palsy. They haven't commented that the other cranial nerve, the other oculomotor nerve being affected.
Okay, and one probably suggestion is that you should also ask the patient if he's hypertensive or diabetic.
No, not diabetic, not hypertensive, normal actually. He
Because-
hasn't been treated for anything. He's very healthy actually.
Okay, because if the pupil is not dilated,
The
and you
pupil
see-
is
no,
not.
I-
It
I-
appeared to react to slightly less rapid than the contralateral side, but it is not a definite third nerve palsy. Otherwise, we would report it.
Yeah, this is just a suggestion to the other.
Yeah. Is there any other question?
No, I have a suggestion. So if the pupil is not dilated, that means you're safe. Okay? But if the pupil is dilated, you have to have a CT scan at least, or an angiogram to
That's
be done.
true. Okay.
Okay?
Yeah.
Yes, just-
Can you use the microphone?
What's the status of the nasopharynx endoscopically and on radiogram?
You mean the appearance of the nasopharynx? Normal.
Normal.
In fact, you can, in the previous CT scan, you can have a rough look at it. But everything else is normal.
Involvement.
Carotid artery.
Yeah. Visual involvement. If there any evidence for this case
You mean
about
carotid artery?
carotid involvement or other vessel involvement?
Clinically, that's not clinically. But this is certainly, as raised by previous speaker, one of the differential, maybe at this stage, our differential diagnosis at that time, a few things. First of all, it can be a tumor. Secondly, it can be a fungal sinusitis. And thirdly, it can be something vascular, so like a carotid aneurysm. Even though it may not be a primary carotid aneurysm, the carotid canal can be dehiscent. And if we need to do something, we need to confirm that the carotid is not dehiscent. And that is a few things that is on our mind at that time. Is there any other comment?
I think the only thing before you go to further radiology is to just look at the scans, probably not
Yes.
the soft tissue, but the bony window scans. And you can see that what you're trying to look for is evidence of which is the best differential diagnosis. And when you start to look at the scans, you see at the back of the sphenoid sinus, you've got significant hyperostosis.
Yes.
So you've got new bone formation. So whatever this process has been there for a long time.
Yeah, that must be.
And this here, is this a moth-eaten appearance or is this a pressure erosion appearance? So you're going to be thinking to yourself, if it's a tumor that's invasive, then you would expect a more moth-eaten looking appearance. Whereas a tumor, say a fungal or a benign tumor that erodes would give you a more pressure-looking erosion. And that's the sort of thought processes that you'd go through before you looked at your...
True. That's the few differential diagnosis. In fact, the top of the list is fungal disease. Because fungal disease, as discussed with our radiologists, they can actually cause different things on the same site. On the one hand, it can cause pressure erosion. On the other hand, because of the chronic inflammation, it can actually cause new bone formation. And this is one of the top of our differential diagnosis. But the unusual thing in this patient is that the patient is not immunocompromised in any way.
Yeah, fungal balls often like that in the elderly
That's
patient.
true. But we still, at that stage, we cannot exclude the possibility of a tumor, actually.
No, you can't. No, because
We
it's
can't.
erosive.
And so the next day, with the few questions in mind, actually we asked for MRA and MRI to be done at one go. And the MRA is completely normal. I'm not showing it the angiogram, but I'm going to show you the MRI. So we have discussed the first point. At that stage, we do have a few differential diagnoses. And we order an MRI and an MRA, which is actually, if you can raise the interest of the radiologist, you get it very quickly. Within 3 days, we get everything done. And the MRI, I'm not showing it here, but the MRI shows that it is a homogeneous mass with heterogeneity inside, and there was no evidence of a soft tissue tumor that directly invade into the cavernous sinus. So with that, we are pretty sure it is most likely a patient with fungal sinusitis. What I would like to show you now is a very short video clip. If I can make it work. Here's the appearance. You can see the rest of the nose is normal. Some mucous pus draining down from the sphenoethmoidal recess. Okay. Then what I would like to show you is the last bit of the surgery. We do a big sphenoidotomy. We remove the lower third of the superior turbinate, and we make a big hole so that we can have a good look inside the sphenoid sinus. We saw the typical material or fungal material that come out, and in fact, the histology later come back. The diagnosis is confirmed. Just like to show you the picture. Here is an area that, apart from the generalized mucosal edema and the fungal material, here possibly is a small localized abscess superimposed on the fungal sinusitis, that we can get a little bit of mucous pus from the posterior superior wall.
Yeah, I think that shows very nicely, John.
Oh. But at that stage, although clinically we think it is fungal sinusitis, we haven't got any proof yet. But the important thing is, by the next day after surgery, the patient's headache is completely gone, although the patient's sixth nerve palsy persisted. And we continue with another week of antibiotic. And early next week, the histology actually comes back, and it is positive for Aspergillus. So the diagnosis of fungal sinusitis was confirmed. But here we do have some problem now. And this is problem I want to pass to all of you here. Because we would like to treat the patient the best way we can. And the most traditional and the most reliable treatment is amphotericin B. At that stage, we stopped the antibiotic, we switched to antifungal, amphotericin B. But the patient cannot actually finish the first dose of amphotericin B. He developed immediate reaction with chills and vigor. We have to stop the treatment halfway. And the next day, we consult our microbiologist again, and he suggests this relatively also quite expensive treatment, itraconazole, but the patient apparently can tolerate at that time, and we treat the patient as inpatient for a few days and send the patient home with further medication. Our plan at that stage is to treat the patient for a minimum of 6 weeks, which is recommended in the literature. But we are also quite sure from the literature that nobody actually knows how long it should be treated, and we need to gauge the treatment from the patient's clinical response. But unfortunately, the patient developed a delayed reaction. About 2 weeks after initial commencement of treatment, the patient was readmitted to the hospital with vomiting and also seemed to be slightly drowsy. At that time, he was actually admitted under the neurosurgeon with the history of fungal sinusitis and previous surgery just the week before in the sphenoid sinus. They are actually worried about intracranial sepsis. And that's why a CT brain and lumbar puncture is actually performed. And this is actually come back to be all normal. The lumbar puncture is completely normal. And the CT brain at that time actually shows that the sphenoid sinus is actually start to become aerated again, which is only 2 weeks after the surgery. And what I would like to show you now is the postoperative progress of this same patient. This is when the patient is still treated as inpatient 1 week after surgery. You can see the appearance of the mucosa. You can see that the lateral wall is actually pulsating. At operation, when I palpate, it is really very soft. And here is the area of the localized abscess that I mentioned at the end of the operation. It seems to be collapsing completely and just replaced by a scar.
That would have been my only concern, John. I would be interested in an MRI scan with contrast in the view of the fact the patient's persistent diplopia to make sure that you didn't have any residual pus collection in that region.
The patient did have after this. And then 6 weeks, now the patient is readmitted under the neurosurgeon, and then we take him over, treat him with antifungal, and now it's about postoperative 6 weeks. You can see actually the mucosa healed very well. Here is the area of concern, but the mucosa, I think, is absolutely normal at this stage, as far as endoscopic examination is concerned.
That's not a bubble of pus or something there, is it?
No, it is actually dry, actually. Nothing coming out. Very dry, actually.
Has he still got his diplopia now?
He's still got his diplopia. So at this stage, our problem is with treatment. So the discussion point number 2 is, how are we going to treat this patient? And we have consulted the microbiologist as well as the physician from the infectious control team in our hospital. We have discussed a few possibilities. Amphotericin B is the classical treatment, the least costly, but with a lot of side effect. If we cannot do that, we can choose a lot of the other alternatives. But all these alternatives are very expensive. And this one I can quote you a figure, which is prepared actually by Dr. Tang from our unit. You can see, if we are using amphotericin B, the normal recommended dose, it is $4.5 per day. If we are using this liposomal amphotericin B, normal recommended dose is, let's say, $440 per day. And all the others is also relatively expensive. But on the other hand, none of this, we do not have a lot of data on any of this treatment. As what is commented by the Professor Wormel just now, the problem with antifungal treatment is with the newer regimens, we actually do not have a lot of clinical data. So for this patient, our problem at this point is that how long are we going to treat? Maybe let me summarize. The patient is now still receiving amphotericin B, but at a reduced dose. It is only about 2/3 the normal recommended dose. But having discussed with the microbiologist, one of the problem with antifungal treatment is always that the dose is limited by the renal toxicity of amphotericin B. And then, but the literature also suggests that the amount or the dose is actually not the absolute limiting factor. When we treat with amphotericin B, it is the accumulative dose to the tissue that will ultimately alter the course of the disease. And so if we are using a reduced dose, the course of treatment will be significantly lengthened. And this is the trade-off that we are facing at the moment. But all the other alternatives, I think it is actually it's unaffordable by the patient, and it is also unaffordable by the hospital.
My suggestion would be to do another MRI scan.
We have done 2 more sets of MRI scan. One of the reasons we have discussed this possibility of complication with the infectious team control, we have repeated 2 sets of MRIs since operation, and we show that the enhancing mass in the cavernous sinus is actually getting smaller, but still there. But it is progressing slowly.
John, I don't know if anybody's got a suggestion as to what would mark the end point of treatment, as you stated in your slide here.
And we have Dr. Tan has also helped us to search the literature, and for patient maybe not exactly a fungal sinusitis, for those with 6th nerve palsy, after successful treatment, the 6th nerve palsy may not recover. That is one problem. We cannot base our treatment entirely on complete recovery of the 6th nerve. On the other hand, if we are not treating the patient at this stage, one of the the risk raised by the physician is that because of the enhancing lesion in the cavernous sinus, there's a possibility that the inflammation will affect the internal carotid one day, and then we can cause an acute complication.
I just wanted to ask our ophthalmologist about that resolution of the sixth nerve. If you have a process that is active, that causes the sixth nerve palsy, would you expect that sixth nerve to recover once the process is gone, or is it unpredictable?
If it's a growing mass, it might have invaded the nerve, so it could be permanent. But if it's an aneurysm, after you refer that to the interventional radiologist and that subsides, definitely it will, the next day, it will already
recover.
But if it doesn't recover after like probably 6 months, usually our timetable is 6 months, then you could probably refer it to a pediatric ophthalmologist, or a muscle surgeon. He does that very well too.
This one, in this particular case, it was a sudden onset, and it's an inflammatory process associated with a fungal infection. And under these circumstances, if that process became quiescent, would you expect, under these circumstances, it was within 2-3 weeks that...
Usually we wait 6 months. Then after 6 months, and if still not improving, and then that's it.
So we can tell whether it is going to recover or not retrospectively. We cannot predict.
You cannot.
My question is actually aimed at exactly what Professor Wormold's getting at, is can we insinuate that there is a continued active process going on there, and what we need to try to do is to discover, investigate, and or find an aggressive treatment if that indeed is continuing to be active.
How's the pupil?
Pardon?
How's the pupil?
The pupil is actually reactive.
I mean,
it's not dilated, it's normal.
Is it both? Is it an
It's
isochloric
equal and reactive on
equal?
both sides.
Oh.
Equal and reactive.
So it might
the only
improve.
time that we are having a small question mark is at the initial phase of presentation, when the patients had clinically totally ophthalmoplegia, and when we test the pupil reaction, it appeared to be slightly more sluggish on the affected side. It's never dilated.
But is there an improvement with the pupil? Is there an improvement with the pupillary
Yes. Now it
action?
becomes obviously equal and
because the pupillary
reactive.
fibers of the third nerve are situated in the external portion of the nerve. So when there's a mass, that's the one that's first affected. So if that heals, it might improve. If
I think that is
if
improved.
the pupil is improving, it might still improve. Then the nerve might.
That is now quite definite that the third nerve is functioning. The only time that we have a question mark that the third nerve may be affected is before surgery, when the patient's pupil reacts slightly differently.
May I ask you, PJ, would you classify this patient as having invasive fungal sinusitis?
Shame I said again, you always ask the right questions. At no point, as far as we've seen to this point, have we shown fungal tissue, if the fungus invading the tissue. We've shown that there's fungus in the sinus. We haven't shown that the fungus is in the tissue. And in the patient who's not immune compromised, that the likelihood is that it's not. So the likelihood is that systemic antifungals are not going to make a large difference. And what I would suggest is the key or the answer in this patient is that if there is an inflammatory mass within that cavernous sinus, that we should potentially explore that through the sphenoid sinus. Now, if you've done any cadaver dissections on the cavernous sinus, you'll note that the third nerve is fairly lateral within that cavernous sinus. The fourth nerve and the sixth nerve are much more closer to you in terms of your dissection. But if you have a decent MRI scan, image-guided MRI scan, you can do a delicate dissection within that cavernous sinus, and you can make sure that you don't injure the carotid artery, which is obviously a concern. You'd need to warn the patient significantly that you will damage the fourth nerve or the third nerve as part of that exploration, but there is a chance if there's an abscess that you can drain it and the patient can actually get better. So I think the key here is the fact that John saw an abscess at the original surgery, And I think we must keep that in the back of our mind, and we've probably got a walled-off abscess within that cavernous sinus. And I would be chasing that and looking at trying to drain that surgically if we could.
You see, we have a dilemma here because we do not have a cavernous sinus thrombosis. We had an active process going on in the sphenoid sinus that had pushed through, broken through the sphenoid wall with that hyperostosis, so that had been ongoing. So there was an inflammatory process, but we always bear in mind that these fungal balls type processes are more saprophytic. In other words, they're living in conjunction with their host. But we have a very serious complication here in terms of that diplopia and the sixth nerve palsy. Now, we would like to know how far and how actively do we go and treat the patient. It's complicated further by the fact that the patient does not tolerate the antifungals well. Of course, they're also expensive. And we don't actually know whether the antifungals, exactly as you say, are helping at all.
Yeah, my feeling is that this is still potentially, and I'd very much like to see the follow-up MRI scans with the contrast to see how close the inflammatory lesion is to that wall of that sphenoid. Is it a millimeter or two of tissue that's separating us? And then you could go and probe that region with some probes to see if you could elicit pus. If you did get a flush of blood, we get cavernous sinus bleeding from the cavernous sinus with the pituitary tumours all the time. The cavernous sinus bleeding doesn't worry me. In fact, you might get a flush of blood from the cavernous sinus at the time. You're concerned about injuring either the carotid artery or the other nerves within that cavernous sinus, and I think you'd need to talk to the patient about whether he'd wish to undergo the risk of such exploration. But if there is the opportunity to explore such an inflammatory mass, that's what I would be going for, because I don't think that you're winning at the moment. The patient's not getting better.
The patient's not getting better, although on the MR there is an improvement in the appearance. But I'd like to say, if there's one structure in the body that contains, there is no other structure in the body that contains more susceptible, damageable organs than the cavernous sinus. And to go and explore the cavernous sinus is definitely not for your average faint-hearted surgeon.
Neither of those, yeah. But
I mean, you're going to have to warn the patient that there's the carotid artery, there's all these cranial nerves going through there.
Yeah, that's why image guidance, and I would use MRI, not CT image guidance, because you get more accurate anatomy in the cavernous sinus than you would with the CT.
PJ, just now you are talking about medical legal aspect. If we don't give antifungal right at the beginning, will there be any medical legal implications?
I don't think so. There's no evidence of invasion. So I think without evidence of the fungus invading the tissue, there's no literature evidence that your antifungal make any difference. So we know that if you look at all the other sinuses, unless you can show that there's fungal invasion of the fungus into the tissue, we know that systemic antifungals are not supposed to make any difference at all. There's no evidence that they do. So I can't see how you can get medico-legally knocked for not having put the patient on antifungals. I think it would have been more important, in my opinion, to have kept the patient on antibiotics, because you might have had a secondary bacterial colonization of that area, and that's why you could see the pus when you were doing the surgery, and that I would have kept the patient on long-term antibiotics over that period of time and not stopped the antibiotics.
The patient had a 2-week course of intravenous antibiotic, and after that we switched to antifungal.
I'm just saying that I don't think it's the fungus. I think don't be led astray. I think it might be an ongoing suppurative process within that. And we're all speculating, but that's the fun of a panel, that you can sit here and you can pontificate.
That's true. And in fact, actually, if we happen to have another first course next year, I will tell you the result.
Is there anybody in the audience that's got a strong view on this particular case?
May I?
Yes, please.
Well, the last few slides you presented, the nose is already quiet and dry.
The sinus is completely normal, actually.
Yes. The only problem is
the sixth nerve palsy
and
a residual enhancing mass in the cavernous sinus.
Yes. Now, fungus is usually, as you mentioned, the cause is immunosuppressive deficiency. And this is a 75-year-old male patient. And first, you have not presented the blood chemistry of this particular patient.
We actually asked his permission for us to take an HIV,
Yes.
screen for his HIV, which is negative.
Negative.
Negative. Although he is not in that high-risk group, I still ask him for permission to check his HIV status, and it is negative.
Now, the patient is not receiving any medication at the present time.
At the moment, only antifungal. At a
Antifungal
reduced dose,
of
amphotericin
minimal
B.
dosage.
Huh?
Of minimal dosage. you said.
Approximately 60% of the recommended dose. The
Yes,
recommended dose is up to 1 milligram per kilo per day. At the moment, we are treating it at the highest level is 0.6 milligram per kilo per day.
Now, what I would like to ask even the consultant here is, can we try a massive dosage? Because this is an inflammatory disease. Maybe, as mentioned, the nerves are affected by this inflammatory process. Now, can we try a short-term massive dosage of steroids just to determine if that steroids can correct the palsy caused by inflammatory process? A short-term massive dosage of antibiotics.
Of steroids.
I cannot answer this question personally. It is so difficult.
Is there any reason
it may not
to?
work.
Is there any reason not to do that?
I think if you covered the patient with antibiotics through the period of administering the prednisolone, you should be relatively safe. I think that you may get a transient slight improvement, but I think if you've got a focus of pus there, I don't see how many milligrams of prednisolone you'll give. I don't think you'll be able to reverse that inflammatory process sufficiently for the nerve to recover. The nerves are very sensitive and very delicate, and you've got to remove that inflammatory process completely, I think, before you'll get an improvement. And even if you did get an improvement, say the sixth nerve palsy did get better, how is it going to alter your further management?
If the patient is asymptomatic, probably I would stop all the treatment.
So let's say that you give the patient large doses of prednisolone, and the sixth nerve palsy disappears. Okay, and then you stop the prednisolone and it comes back. So how has the prednisolone altered your management?
I think I would pursue on a more conservative approach. I was certainly not thinking of exploring that site.
Would you stop the amphotericin B?
I would stop the amphotericin B and wait. Maybe 6 months later, as suggested, it will improve.
Or would you put the patient back on steroids?
Back to what?
Back to steroids. In other words, you've got to think, if you're going to do a manipulation, how is it going to change your management?
Yeah, at this stage it's difficult, but at least the patient has no more headache, which is a good point.
I think it's an interesting topic because, I mean, if you gave massive doses of steroids, it might well decrease the inflammatory response. But does that mean to say that you shouldn't explore it? It might mean that there's a stronger indication to explore it because that you know that it's an inflammatory process. And if the MRI does show that there's potential of pus within that inflammatory process, then you might be more inclined to explore it. If the MRI shows that there's no liquid or fluid within that inflammatory focus, then you might be inclined to give the patient long-term steroids. In other words, for a couple of months to try and reduce that inflammation, improve the function of the nerve.
I think it needs a close communication with the radiologist and detailing exactly what we're looking for so we get the highest resolution MR with a contrast there. And, it's very easy to sit here and to talk in black and white terms, but the MR and the CTs are various shades of grey. And it would be nice if we got a clear answer. But I think that one also has to balance the risks of going ahead and exploring with the potential complications and the potential benefits. And so we're going to have to make that call when we get in time. And I think what we will do is get in time the best possible MRI to see if that process is localized, ongoing, rather than a diffuse inflammatory process.
It's also the experience of the surgeon. You know, if you've got surgeons who are used to operating around the cavernous sinus and have had occasion to have opened the cavernous sinus and seen what it's like to deal with the bleeding from the cavernous sinus and all that sort of stuff, they're much more comfortable to go in and do that sort of exploration, whereas somebody who's never done that probably shouldn't. You know, you've got to look at whether you are able to or not. I think that's the...
Exactly. I have to take all these considerations into account. We'll tell you next year what happened with this. Do you want to tell us about what happened with that case last year, John?
So another one from last year, you want?
That child that we discussed last year. You can just tell us briefly.
Let me see.
That is a good case, John.
I don't know whether I got it here. Maybe it is this one. Okay. There's another case actually. Again, fungal sinusitis. This is a case that we presented in the panel discussion last year. Just very briefly. This is a patient who is immunocompromised. He's a 11-year-old boy with a known history of acute myeloid leukemia. Again, he has been completed his treatment with his leukemia, but it's not well controlled yet. He was admitted at the end of last year with right-sided headache and facial tenderness and neck pain for 1 week. And that was his past history. He has acute myeloid leukemia diagnosed in 1999, and by November 2001, he has completed all his treatment, and he actually go through the process of total body irradiation and bone marrow transplant. But unfortunately, his condition is not actually well controlled. And he was admitted on December 20th, 2001. The general status, very poor, appeared to be very tired, but he was afebrile at that time. He's obviously pancytopenic. I can't remember the figures, but it's very bad. And at that time, the differential diagnosis include intracerebral relapse or severe sepsis. And the patient was treated with a high dose of powerful intravenous antibiotic. And the next day, the patient presented with epistaxis, and we are actually consulted. I think maybe one other thing that I would need to, By day 4, they have arranged a CT to be taken. The CT actually needs to be wait for quite a few days, unfortunately. And on day 4, they get the CT scan available. Essentially, that was actually looking for brain pathology. The brain, the orbit, and the sinus is also cut through, but the sinus is only briefly cut through, and it shows that the right sphenoid sinus, the frontal, ethmoid, and the maxillary sinus are opacified. So on the right side, completely total pansinusitis. But there's no overt enhancing mass lesion, no bony destruction to the cavernous sinus. And the patient was diagnosed to have right-sided pansinusitis. And this is his set of CT scan. The axial cuts, you can see the right side totally white out, all the way to the sphenoid. So we are consulted with this sort of information available, and the patient is very uncooperative and cannot actually cooperate with even simple nasal endoscopy. But there was no obvious rhinorrhea. And at that time, the doctor who saw the patient decided to treat the patient in a more conservative manner with just intranasal enterostomy, wash out the sinus. And at that time, we also take a biopsy from the right middle meatus, which later come back to be, again, Aspergillus. And so the diagnosis of fungal pansinusitis was diagnosed at that time. And a suction catheter at that time was left in situ for irrigation. And as far as the progress is concerned, a few days later, the histology come back to be fungal hyphae demonstrated. And there's also inflammatory granulation tissue from the biopsies. And the antifungal treatment was added by the pediatrician, which include amphotericin B, itraconazole, and the patient is also receiving rosafin at that time. And by January the 9th, the intramaxillary drain was removed, and CT scan was repeated. And at that time, but there was no clinical or no radiological improvement. But although the patient's clinical condition remained relatively stable. And this is a repeat CT scan, still pansinusitis on the right side. No improvement. And actually, it was while we are having our first course last year, the patient suddenly kicked up a swinging fever, and he has on and off a blood-stained nasal discharge for a few days before our first course, and we are consulted again. I think at that time, maybe I should not maybe at that time the decision actually after a lot of discussion is perhaps radical. If we do not treat the patient, obviously the patient was at a very poor state, very critical. But at that time, I think the advice from the panel, especially from PJ, is that if we do not do anything, probably the patient has no chance. If we are going to do something, perhaps the patient still have a chance. And actually, this is what we proposed to the pediatrician the next day after the first course. But unfortunately, at that time, the patient's condition seemed to be getting worse again. And another set of CT scan, the patient also developed a multiple cranial nerve palsy. And another CT scan repeated the next day after the first course, so that the patient had actually got bilateral cavernous sinus involvement. And at that time, we are still not sure whether it is the leukemia which relapsed or it is sepsis. But the fact is the patient died 2 days later. So it is actually a lesson to be learned. If we are going to do something, maybe if we do something more aggressively in the first place, maybe we can help the patient, although not guaranteed. But as was suggested, the patient may still have a small chance. But if we are not doing anything or not quick enough, maybe the patient even lose that little bit of chance. Just gives you a follow-up of what happened to the patient.
Thanks, John.
Do you have your next case?
Do you have another case?
Actually, I can present another case which is more ordinary level that we may encounter.
I think we should have that, and if there's time, then we'll show PJ's video.
A question regarding the last presentation?
Yes.
Sure.
Did you schedule the patient for FS in this particular
You mean
pediatric?
at the first consult or at the last consult?
A patient with acute myeloid
Acute myeloid leukemia.
Well, any patients with leukemia, they can really bleed during the
Yes,
surgery.
yeah.
Yeah, we had this discussion at the last first course quite extensively as to whether and why and what the indications were. And our feeling is you've got to get the platelet count above 60,000. So you've got to give the patient platelet transfusion, make sure the platelets are up to 60,000. Then you can go and do the FES. At the end of the FES procedure, if you've got significant oozing, you pack the nasal cavity with a bit of fibrillar Surgicel and thrombin, and that'll stop the oozing. So just because the patient's got leukemia doesn't mean to say they can't have surgery.
But I think the ultimate point of discussion is if we don't do anything, the patient may have no chance. If we do something, the patient may still have a small chance. This is actually a very interesting case, but can be quite tricky. It is a 14-year-old boy with a long history of nasal catarrh, admitted to the pediatrician with 2 months history of severe right frontal headache, so much so that the pediatrician need to admit him for further investigation. And despite the full course of antibiotics and the analgesics, which is the patient taken regularly, is still not being controlled. And at last, the pediatrician do a CT scan for the brain. And again, the brain is completely normal, but incidentally, the frontal sinuses on both sides was incidentally picked up to be opacified. And the ENT team was consulted. And on examination, it came as an urgent consultation. And the patient was afebrile. Nasal endoscopy was normal and remarkable. Our registrar who saw the patient suggested the patient should have a coronal CT with contrast. And with the results available, we would like to see the patient again. And meanwhile, the patient's headache is still going on, although the patient is afebrile, but he's still being treated as inpatient. That means the headache is relatively severe. And a few weeks, more than 2 weeks later, actually the patient, we are reconsulted when the CT scan become available. But unfortunately, although we write it down very carefully, saying that we require coronal CT with contrast, but no contrast was given. And this is the set of CT that we have at the second consultation. Completely opacified sinus. Ethmoid, maxillary, everything is opacified. If you take a look, inside the nasal cavity is relatively normal, but all the sinuses is completely opacified, perhaps with the exception of the left sphenoid sinus. Any comment?
Has the patient been on medical treatment, John?
All the time on antibiotic.
Nasal congestions, douches, all that sort of stuff?
Probably not. He was in the pediatric ward.
Yeah, because I mean, the optimal treatment would have been to put the patient on a decongestant, systemic and topical nasal douches, and consider a short course of prednisolone in addition to the antibiotics to see if you can get some resolution. Prednisolone was certainly not given. We haven't actually suggested a course of topical steroid at that time. But because of the headache, at the second consultation, I happened to be the one who saw this patient. And it was the day before our routine list surgery. So I saw this patient, he has a lot of symptoms. And he has been treated apparently very adequately with antibiotic at least. I'm not sure about nasal decongestant, but certainly steroid was not given, systemic or topical. So, and on that afternoon when I saw the patient and I look at the list that I have for the next day, probably we can slip it in and do some surgery, do some fast surgery for this patient. And that is in fact what I did. So the patient is quite fortunate. We have maybe a slot of time that we can slip the patient in for surgery the next day. The reason I do that is the patient was already inpatient and the patient has a lot of symptoms. But unfortunately, he was added to the last of the list. And the previous cases overrun. And I was having the dilemma because the anesthetist would not like to continue. He would like me to cancel the patient from the list. So at this point, I would like to ask the audience. What will you do? Will you cancel it from the list or what will you do? It happened quite frequently, actually. I think the answer is pretty clear, John.
Yep.
I always see things in black and white and lesser shades of grey. If you've made the diagnosis that the patient has frontal sinusitis, which is non-responsive to medical treatment, which is what you've presented to us, then the patient needs a surgery, and there's no question that you should cancel the patient.
Yeah. So you
continue,
insist.
Yeah.
That's what I did actually. Unfortunately, I have to do it as an emergency. I have to switch it to start wait as an emergency. And this is what I found actually. This is right after both sides. The left side is essentially quite straightforward. This is the right side, again with a localized abscess, which is right at the scalp base. I'm not 100% sure whether this is actually through the scalp base, because by the time when I open up the last ethmoid cells, this is what I found. And together with the history that the patient got very severe right-sided frontal headache, and this worries me a lot actually. And I'm quite glad that I insist that I do the operation even as an emergency. I'm not going to show you the whole video, but just some point for discussion. And I always remember, this trapped me a few times, nearly trapped me a few times. For a patient with sinusitis and a severe headache, we have to be very careful all the time. I wonder if you have the same experience or if you agree with this general statement.
That's why I said a frontal sinus disease that's non-responding to medical treatment needs surgical correction. And you really must make sure that there's no intracranial complication. And that's why insisting that the CT scan is done with contrast on both soft tissue and bony windows, and including intracranial cavity is important.
Yeah, that's quite true. In fact, if we have not done this, we don't know what can happen. If the patient suddenly had this sepsis further spread intracranially, then we have a lot of responsibility. Particularly if I have put it on the list and cancel it for our next elective list. The problem for us is the next elective list may be a few weeks later, unfortunately. So I'm quite glad that I nearly trapped by this case. And eventually the patient make a very good response. This is the contrast-enhanced CT scan that I insist that has to be done the next day, and which shows that there's no actually localized abscess. And more than that, there's no intracranial gas. At least I have not created, I have not penetrated the skull base. And subsequently, the patient has another 2 weeks of intravenous antibiotic. And the patient was subsequently discharged, maybe just very briefly. And postoperative, 4 weeks later, when I saw the patient in the outpatient, he's actually doing very well. No more headache at that time, and we put him on topical steroid, and he's still being followed up. I think I can stop here. But I think the lesson to learn for me at least is beware of the patient with sinusitis and headache. The headache in this type of patient are always very severe. We cannot explain it why.